Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome back to the deep dive. Today, we are really cutting through the complexity of acute trauma management. We're going to distill the absolute core of the trauma bay's operating system, the Advanced Trauma Life Support Protocol, or ATLS.
Right. And for you listening, whether you're a surgeon, an ED doc, maybe a resident about to start a critical rotation, this isn't just theory.
No, it's the discipline backbone of how we save lives. Our mission here is to pull out the most actionable insights, flag some common failure points, and look at the new evidence that's shaping this framework.
It's so true. And, ATLS was really born out of necessity. It's the global gold standard now, taught to, over 1 million doctors since the American College of Surgeons formalized it back in 1980.
And it all started with that one incident, right? The story of Dr. Steiner.
Exactly. Dr. James Steiner, an orthopedic surgeon, experienced the catastrophic failures of disorganized trauma care firsthand after a plane crash. He realized the world needed a universal, prioritized language for trauma, and that's ATLS.
Okay, so before we get into the nuts and bolts, we have to state the disclaimer.
We do, and this is critical. This deep dive is for reference and educational purposes only. You must always, always follow your local institutional guidelines, your hospital protocols, and your regional standards of care when you're managing any patient.
Right. Let's get into it. So let's start with the philosophy, because that's really what sets ATLS apart from just, a simple checklist.
It is. It's about fighting the natural clinical impulse to chase the most dramatic injury.
Okay, so what are those core premises?
Well, premise one.
Yeah.
You must treat the greatest threat to life first. It's non-negotiable. So if a patient has a massive bleeding femur fracture, but also a compromised airway, you deal with the airway first.
Even with all that blood?
Even with all that blood. Then premise two. You have to proceed with treatment without waiting for a definitive diagnosis. You don't wait for a chest x-ray if the patient is clearly in tension pneumothorax.
And the third?
A detailed history should never delay resuscitation. Ever. You get to that later.
It seems so logical laid out like that, but in the chaos of the moment, why is this systematic approach so critical? Is that risk of paralysis and omission really that high?
Oh, it is. The cognitive load during that golden hour is immense. You have multiple threats, alarms going off. It leads to tunnel vision. ATLS imposes order on that chaos.
By breaking it down into phases.
Exactly. It all starts with a primary survey. That's your rapid, maybe 10 to 15-minute window to find and fix what's going to kill the patient right now. And resuscitation is happening at the same time.
And once you've achieved some stability,
only then do you move to the secondary survey. That's your meticulous head-to-toe exam.
Yeah.
You can only do this after the primary survey is done and the patient's vitals are starting to normalize.
And then there's a third one, which I think is so often overlooked.
The tertiary survey. And this is so important for patient safety. It's a complete top-to-bottom repeat exam, usually done within 24 hours of ICU admission or after their first surgery.
And the data on this is just staggering. Without that formal 24-hour check, missed injuries are around 9%.
That's right. And with a formalized tertiary survey, that number drops to 3.4%.
That is a massive difference. Almost 1 in 10 patients having a missed injury is a huge vulnerability.
It is. The tertiary survey isn't optional. It's a mandatory safeguard.
Okay, so that really drives home the importance of the system. Let's dive into that rigid, sequential discipline of the primary survey itself. A, B, C, D, E.
Right. Starting with A, airway maintenance, with C, spine precautions. The first check is, simple. Can the patient talk?
If they're speaking clearly, the airway's probably okay.
Probably patent, yes.
Yeah.
If not, we have to intervene immediately. And any airway maneuver, like a chin lift or jaw thrust, must be done with meticulous inline cervical spine immobilization. That's often a two-person job.
And that can be one of the hardest things to coordinate in a crowded, chaotic trauma bay. Now, what about the decision point for a definitive airway, for intubation?
That is a clinical red line. A Glasgow Coma Scale, or GCS, of 8 or less means mandatory intubation. It's not a suggestion. It's the standard of care to protect the airway in a severe head injury.
And if intubation fails?
You move immediately to a surgical airway, the cricothyroidotomy. No delay.
Okay. Airway secured, we move to B, breathing and ventilation.
Right. And here we're inspecting the chest. We're looking for tracheal deviation, asymmetric movement, a flailed chest. But the big one, the immediate life threat, is a tension pneumothorax.
Which requires immediate needle decompression. And this is interesting because the evidence here has been evolving, hasn't it?
It has. The classic spot we were all taught was the second intercostal space, midclavicular line.
Right.
The current ATLS recommendation actually shifted that to the fourth or fifth intercostal space, just anterior to the anterior axillary line.
But there's a nuance there, isn't there? Especially with different patient populations.
There is, and this is something clinicians really need to know. Emerging evidence suggests that in obese patients, because of the increased chest wall thickness, that traditional second intercostal spot might actually give you a higher success rate with a standard 50-millimeter catheter.
You have to know the anatomy you're working with.
You do. It's a perfect example of how we have to adapt. Now, for an open pneumothorax, it's a sucking chest wound, the fix is much simpler.
A three-sided dressing.
A three-sided dressing. You tape it on three sides, leave one side open. It creates a one-way valve so air can get out, but not in.
Okay, let's move to C circulation and hemorrhage control. This is where I think experience really comes into play, especially because of what you could call the myth of normal blood pressure.
Oh, absolutely. That is the classic trap ATLS tries to prevent. The patient could have bled out 30% of their blood volume before their systolic pressure even starts to drop.
So what should we be looking for?
You look at the patient, not just the monitor. Pale, cold skin, and a rapid, thready pulse. Those are the true signs of shock, even if the monitor is still telling you the blood pressure is okay.
So before we even think about fluids, the first job is to control the bleeding. What's the hierarchy there?
Direct pressure is first, always. It's the most effective initial step.
And tourniquet.
They're reserved for life-threatening bleeding that you just can't control with direct pressure.
Right.
Or for, a traumatic amputation, you place it 2 to 3 inches proximal to the wound, avoiding the joint.
And the goal isn't to obliterate the distal pulse.
No. The goal, the only measure of success is that the external hemorrhage is stopped.
Okay, bleeding is controlled. Now we resuscitate. We hear a lot about damage control resuscitation now.
That's the key. We start with 1 to 2 liters of warmed isotonic crystalloid, infused rapidly. But we transition to blood products quickly if the bleeding continues. We're not aiming for a perfect blood pressure.
You're just aiming for good enough.
Good enough to perfuse the vital organs. The goals are roughly a heart rate under 120, systolic over 90, good cap refill, and making some urine. We want just enough to survive without over-resuscitating and blowing the clots.
Right. Then we get to D, disability.
This is our rapid neuroassessment. We use the GCS, and again, if it's 8 or less, that mandates a definitive airway. We also do a quick check for reversible causes, right? Hypoglycemia, opioid overdose, things that can mimic a brain injury.
Good point. And finally, E, exposure and environmental control.
We have to completely undress the patient. You will miss injuries if you don't, but you have to immediately follow that with warming. Hypothermia is a killer. It starts that lethal triad acidosis, coagulopathy, and hypothermia that just spirals.
And while all of this is happening, we're using our primary survey adjuncts.
Exactly. The fast exam to look for free fluid, a portable chest x-ray, a portable pelvic x-ray for unstable fractures.
And remembering the contraindications.
Critical. If you see blood at the urethral meatus, no urinary catheter, and if you suspect a basilar skull fracture, any gastric tube has to go in orally, not nasally.
Okay, that's a whirlwind tour of the most critical phase. Once the patient is stable, we can transition to the secondary survey.
Right, now we finally have a moment to breathe and look deeper. This is where we combine a systematic physical exam with a targeted history, using the AMPLE mnemonic.
Let's run through that. A is for
allergies, M is for medications, P for previous medical history and also pregnancy status, L for last meal, which is critical for anesthesia, and E for events and environment of the injury, the mechanism.
So with that history in mind, we start the head to toe. In the head and face, what are those subtle signs we're looking for?
We're looking for signs of a basilar skull fracture. So hemotympanum blood behind the eardrum battle sign behind the ear, or raccoon eyes. Those are the big visual clues.
And in the neck, we're still maintaining C-spine immobilization.
Absolutely. But you have to remember that the hard collar can hide injuries. You have to reassess once the spine is cleared.
Okay, moving to the abdomen. This is where one of the biggest clinical traps lies, doesn't it? The idea that no tenderness means no injury.
It's completely false. The abdominal exam is notoriously unreliable, especially in the elderly, patients with altered mental status, or anyone with a major distracting injury. Their brain is just focused on the bigger pain.
So any sign of a seatbelt mark.
A seatbelt sign is a mandatory ticket to the CT scanner, no question.
And for genitourinary and rectal exams.
The digital rectal exam is crucial. You're checking for blood, for sphincter tone, or for a high-riding prostate, which is a huge red flag for a major pelvic fracture. And that goes back to the rule: blood at the meatus, no Foley catheter.
Finally, the extremities. Beyond fractures, we're looking for neurovascular status, and especially for signs of compartment syndrome.
And the number one sign is pain that is just completely out of proportion to the injury. It just doesn't make sense. That, plus a tense compartment and pain with passive stretching. You have to act on that immediately. That needs an urgent evaluation for a fasciotomy.
That need for a rigorous extremity check really feeds back into the importance of the tertiary survey you mentioned earlier.
It does. It's the gold standard for a reason. Injuries get missed in that initial chaos. The patient might have been unconscious or rushed to the OR. The tertiary survey is your safety net.
Let's use a quick clinical example to tie all these surveys together. Say, a patient comes in with massive bleeding from a penetrating leg wound.
Okay, immediate ATLS action. C for circulation. A tourniquet goes on, controls the life-threatening bleed. The primary survey proceeds, you secure airway and breathing.
Then the secondary survey might find, say, a subtle neurological deficit in that leg.
Right, but then the tertiary survey, 24 hours later, is what picks up on an evolving compartment syndrome, a pathology that was completely masked by the initial hemorrhage. That's what prompts the fasciotomy and saves the limb. It shows how this system catches things over time.
And none of this works in a vacuum. It requires a really well-oiled team.
Oh, absolutely. ATLS is all about multidisciplinary collaboration. You need a designated trauma team leader who allocates roles, maintains situational awareness, and is constantly reassessing.
That structured handover is so important.
Crucial. Mechanism, vitals, interventions, and most importantly, the patient's response to those interventions. That clarity is what prevents errors.
Finally, let's just touch on those advanced considerations, how ATLS keeps evolving. We mentioned the needle decompression site for a tension pneumo.
Right, the shift from the second to the fourth or fifth intercostal space, and the new data bringing the second space back into consideration for certain patients.
Or pelvic binders.
Another great example. We went from putting them on almost everyone with major trauma to being much more selective, based on clinical suspicion of an unstable fracture. It reminds you that even a gold standard has to adapt to new evidence.
So to wrap this all up,
I'd say the ATLS protocol is really the universal language that brings order to the chaos of major trauma. Mastering the system, the primary, secondary, and tertiary surveys, it's just foundational for safe, effective acute care.
and I think the provocative thought here is that continuous reassessment. The fact that even something as established as where to put a needle is still being debated and refined, it just underscores that our disciplined sequential thinking has to be paired with constantly integrating the newest evidence. The framework gives you the structure, but it's your clinical judgment, informed by the latest knowledge, that truly benefits the patient. If you found this deep dive valuable for your clinical practice, please don't forget to share it with at least one of your colleagues or friends and help us spread the word about these evidence-based reviews. Also, check out our YouTube and other social media pages for more in-depth content. Thank you for diving deep with us.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.